Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to another session on this channel. As you know, we are discussing the inflammatory conditions of the external auditory canal. So today we will cover another disease which is affecting the external auditory canal. This is the basic slide we are following, and till now you would have very good idea that inflammation of the external auditory canal, broadly they are divided into two main groups. One is infective group, and this infective group is subdivided into bacterial, fungal and viral, and another group is reactive group, which contains the dermatological diseases which can involve the skin of the external ear as well. This bacterial otitis externa can be localized or generalized or diffuse otitis externa and malignant otitis externa. Then there can be fungal infection, which in the ear it is called otomycosis, and certain otitis externa, they are viral in etiology. One is herpes zoster oticus, another entity is otitis externa hemorrhagica, and the reactive group, as I told you, contains the skin disorders like eczematous seborrheic otitis externas and neurodermatitis. So today we will take over this bacterial otitis externa, which is localized. This is an acute condition. This is called acute localized otitis externa. As the name is indicating, disease is acute. Secondly, it is localized. So it means a specified portion of the external auditory canal will be affected by this disease. Rest of the external auditory canal will be normal. This is also called Furunculosis, and in layman term it is called boil. So synonymously all these are called boil, furunculosis, or acute localized otitis externa. So these are different names for the same entity. How it is defined? That this is acute localized infection of a hair follicle. Okay, so this word A is very important. Keep in mind, one thing is that this is infection of a hair follicle. Then infection can be due to many bacteria, fungi, viral, but specifically if it is due to Staphylococcus aureus, then it is furunculosis. So a comprehensive statement will be, or a definition will be, that this is acute localized infection of a hair follicle by Staphylococcus aureus. Or in other words, we can say that boil or furunculosis is defined as a staphylococcal infection of a hair follicle. There is another term in skin diseases is used, which is called carbuncle. The difference between furunculosis and carbuncle is that furunculosis, as I told you and I emphasized on this word A, that single hair follicle is affected by staphylococcal infection, while in carbuncle there is a group of hair follicles next to each other, they become infected. So when a group of hair follicles, adjacent hair follicles, they become affected, then we call it as carbuncle. But if a single hair follicle is affected by Staph aureus, we call it as Furunculosis or boil. So it means boil will occur in the skin anywhere, wherever there will be hair follicles. So from our anatomy knowledge, we know that the cartilaginous portion of the external auditory canal, which is outer 1/3 or lateral 1/3 of the external auditory canal, the skin lining that portion contains the adnexa, means hair follicles and other sebaceous glands. So hair follicles are confined to the outer 1/3 of the external auditory canal, so boil will occur only in the cartilaginous portion. The skin which is lining the bony part or the deep meatus of the external auditory canal is devoid of the hair follicle, so there is no point of occurrence of boil in the deep meatus. It is just like a nose. In the nose also we know that only the nasal vestibule, which is skin lined and hair bearing area of the nasal cavity, there the boil can occur, but not in the nasal cavity proper, which is mucosa lined. Similarly, on your palms or on the soles, the skin is devoid of the hair follicles. So if there is a localized infection there on the palms or soles, it can be anything but not a boil. So Staphylococcus aureus, when it is causing the infection, there will be obstruction of the apopilosebaceous unit, which will lead to the boil formation. So cartilaginous portion only, and patient will be having severe pain, which is aggravated by the movement of the pinna and the temporomandibular joint, especially during chewing. Ecological factors may be multiple. Some patients may be allergic to something, or they are in habit of scratching their ear canal. So when they try to scratch their ear canal, there may be small abrasions, and through those abrasions, the Staphylococcus aureus gets a chance to get into the skin and cause the infection of the hair follicles. And then, as you know, immunocompromised patients who are on chemotherapies or on radiation, or diabetic patients, they are more prone to get infection anywhere in the body, and this ear also cannot be spared from that list. What happens? That bacteria invades the hair follicle and cause the well circumscribed deep skin infection, and a pustule is formed, and if not treated, it can lead to a localized abscess. And along with that, there will be some associated cellulitis and edema. And these bacteria, they attach initially to the stratum corneum and proliferate around the ostium of the hair follicle, causing the blockage of that ostium, which I just mentioned, that the obstruction of apopilosebaceous unit. Now, from the pathogenic strains of Staph aureus, some leucocidal toxins are produced, which trigger the lysis of phagocytic cells and then can have an important role in cutaneous infections. Now, there is another entity which is called recurrent Francolosis. Any disease which is recurrent means that there will be acute episodes of that disease, but the interval in between those acute episodes, patient will absolutely be free of the symptoms. That interval may vary from weeks to months or even years, but there will definitely be history of similar attacks before. So recurrent Furunculosis means a patient comes to you, he says, every 2 months, 3 months, 4 months, I get this boil formation. Anywhere, I mean, either in the nose or in the ear or on the skin, anywhere. So at the time of presentation, if there is acute localized infection, we have to deal with that, of course. But at the same time, if history is suggestive of recurrent infections, then we should investigate that patient, because it means some underlying disease or pathology is there, which may be a systemic disorder. And usually these patients, they are diabetic, either unknown, or even if they are known diabetic, they are not taking proper treatment and sugar level is not controlled, or they may be having hypogammaglobulinemia or dysphagocytosis. So my point is that patient with recurrent furunculosis, you have to deal with that acute presentation on its own merit, but at the same time this patient should be thoroughly investigated for some underlying systemic disorder. Second thing is in recurrent furunculosis that repeated infection, they may cause permanent scarring and fibrosis of the external auditory canal, leading to the meatal stenosis later on. And ultimately, this localized infection, when it is repeatedly there, it may lead to chronic diffuse otitis externa. So, an acute and localized disease may be converted into generalized or diffuse chronic inflammatory disease. So acute furunculosis or boil, which we are talking about, will present with, of course, as I told you, with otalgia. Severe pain will be there, and this pain will be more worse with jaw movements, because we know that temporomandibular joint is in relation with the external auditory canal. And on examination, there will be localized swelling of the external auditory canal on that particular area where the infection is, and this boil will be in the cartilaginous portion of the external auditory canal. If some swelling is there in deep meatus, that cannot be a boil. On palpation, there will be tenderness, and if this boil is present at the interior wall of the external auditory canal, so then we will press the tragus, patient will feel pain, but if we touch the pinna, rest of the pinna, patient will not feel pain. So tragal sign positive means that inflammation is there on the interior wall of the external auditory canal. If swelling is localized and that it is not that much huge to cover whole of the lumen of the external auditory canal, and we are able to look beyond this swelling into the deep meatus and the tympanic membrane through ear speculum or through otoscope, then tympanic membrane will be normal in case of furunculosis, and this will differentiate this disease from acute otitis media, in which case the tympanic membrane will be red and congested. Because this is a bacterial infection, so regional lymph nodes will be enlarged and they will be tender on palpation, and because there will be cellulitis and edema of the surrounding tissues, especially if bile is present there on the posterior wall of the external auditory canal, this post-oral sulcus will be obliterated. It will vanish away because the edema from inside is coming outwards, so this post-auricular sulcus is not visible anymore, and this will differentiate it from the acute mastoiditis, in which case this post-auricular sulcus is more accentuated. And when we will discuss mastoiditis, we will elaborate this point again. So in this picture you can see that anterior wall of the external auditory canal is congested. So in this particular case, if we press the tragus, patient will feel pain, so tragal sign will be positive in this case. Treatment will depend upon at which stage the patient presents to you. In early stages, before the formation of abscess or pus, we have to think about the antibiotics. But this is a routine of the students, just write down antibiotics, analgesics, hospital admission, etc. But no, medicine cannot be that much generalized. You have to be very specific, because now we very well know that this particular disease is caused by Staph aureus. And we know that malignant otitis externa is also an acute infection of the external auditory canal, but there the causative agent is Pseudomonas aeruginosa. So antibiotics which are effective against Pseudomonas, we cannot prescribe here in case of furunculosis. Here we have to go for those antibiotics which are effective against Staphylococcus aureus. till we have got some culture sensitivity report from the ear discharge. Then accordingly we can switch over to sensitive antibiotic. So Staph aureus in routine, they are usually sensitive to penicillin and its derivatives or first generation cephalosporins. Depending upon the severity of the disease, we can prescribe oral antibiotics, but if the presentation is severe, symptoms are more marked, then we can think about injectable antibiotics. Again, analgesics, because patient will be presenting with the pain. So analgesia will be according to the severity of the pain again. In routine, we can go for NSAIDs, which are available, non-narcotics. But if pain is severe, we can think about narcotic analgesia. Again, ranging from oral analgesia to injectable analgesia according to the severity of the patient. Locally, we can advise the patient to do the hot compression that will reduce the edema. We can take a wick and we can soak it with 10% Ecthymol glycerin and we can put it inside the external auditory canal, which will help in reducing the edema. And once the edema is reduced, the pain will be relieved. If abscess is formed, then this is a general surgical principle. Abscess anywhere in the body, you have to drain it. So same principle will apply here, that if abscess has been formed there, we have to go for incision and drainage of that abscess, followed by antibiotic. Now, the mechanism of action of this Ecthymol glycerin is that one thing is that it has got an anti-staphylococcal action specifically, and at the same time it is hygroscopic, that it will absorb the moisture, fluid. So when that fluid, which may be transudate or exudate, that is being absorbed by the wick soaked in Ecthymol glycerin, the edema will reduce in the external auditory canal and patient will feel less pain or his pain may be relieved. And glycerin, as you know, it is a moisturizer, so that dry skin which will happen there later on, this will cause softening and moisturizing of that skin lining the external auditory canal. Another chemical, which is aluminium acetate, its solution can also be used on the wick. It acts as an astringent as well as hygroscopic agent, reducing the edema. Now, recurrent Furunculosis, if patient presents to you with an acute episode, we will treat the patient as discussed. But in between the attacks, when patient is having no disease, we will go for prevention, because we know prevention is better than cure. So we can think about the eradication therapy, that we should eradicate the Staphylococcus aureus. So we can go for oral flucloxacillin for 2 weeks, or in case of nose especially, or even in the skin, if patient is having recurrent Furunculosis, we can go for bacterial interference therapy, because normally we know in the nasal cavity especially the Staphylococcus aureus is present normally there. So deliberately we can implant, there are non-pathogenic strain of Staph aureus. Staph aureus have got different strains. So strain number 502A is more popular and it is non-pathogenic. So we can colonize the skin where recurrent Furunculosis occur with this strain of Staph aureus, so that the recurrence is reduced. So this is what it is called, bacterial interference therapy. Then it is also being seen that there may be some specific biochemical abnormalities underlying. For example, the patient may be anemic, that may be due to hypopheremia. So if his iron is corrected, or a patient is on low serum zinc, so we can prescribe the zinc to that particular patient. So these biochemical abnormalities, if they are dealt with, marked reduction in frequency of infection has been observed. Then eradication therapy locally can also be done with mupirocin, which can be applied in the external auditory canal, If it occurs in the nose, in the nasal vestibule, or anywhere in the skin, if there is recurrent infections, we can use that. And last but not the least, if your patient is diabetic, aggressive control of this diabetes is must. So with that, we come to end of this session. So any queries or suggestions are welcome in the comment section. Thank you very much.